and thank you for joining us at the South Carolina Office of Rural Health as we discuss the Rural Emergency Hospital designation. My name is Emma Jackson, and I have the pleasure of walking you through today's webinar. Here, I will briefly point to today's agenda of everything we will cover, but I will explain today's objectives in greater detail after first introducing myself. As I said, my name is Emma Jackson, and I am the graduate assistant here at the South Carolina Office of Rural Health with the Health System Innovation Team. With that being said, you may be more familiar with our director, Sarah Craig, and our program manager, Britton Herbert, and the work that they facilitate with small rural hospitals across our state. By the end of today's webinar, I hope that you will be able to walk away with a better understanding of how the REH model plays into SCORE's programs and initiatives, have an understanding of how the model operates, as well as the specific criteria and eligibility requirements outlined by CMS for this model. Finally, I hope that you'll be able to understand the REH application process, what technical resources are available to you through this model, and what opportunities may exist to your hospital through the REH model. Now, before we walk through the specifications of the REH model, I want to first touch on the role of SCORE here in our state. In working to close the gap in health status between rural and urban communities, SCORE is able to facilitate a wide variety of programs across health systems and communities here in South Carolina. Today we will be focusing specifically on rural hospital programs at SCORE, such as the Medicare Rural Hospital Flexibility Program, also known as FLEX, and the Small Hospital Improvement Program, or SHIP program. But for a more comprehensive list of all of our programs, I do want to highlight the 2022 Annual Impact Document as a great resource through SCORE's website. That being said, I first want to draw attention to the first hospital program I mentioned through the Health System Innovation Team, which is the FLEX program. Now, by highlighting the 5 main objectives of the Medicare Rural Hospital Flexibility Program, I hope to give you a better understanding of how we're able to engage potential REHs here in South Carolina through our office by the work that we already do with critical access hospitals. For starters, through this program, we're able to initiate operational, financial, and quality improvement initiatives with the hope that small rural hospitals can adopt best practices within their systems, all with the underlying goal of closing the gap that exists between rural and urban communities. In addition to these domains, we're also able to facilitate population health improvement so that hospitals are better able to address the health outcomes of the populations they serve. With those domains in mind, we're also able to engage emergency medical services and support these vital facilities that bring health out into the communities and facilitate transfer to their local hospitals for care. Finally, and perhaps most relevant to today's topic, through the FLEX program, our office is able to initiate innovative model development so that we can promote health system innovation that works to support all 5 of these domains we have discussed. Largely, that innovation is able to occur through the critical access hospital model that you may already be familiar with, and through the new rural emergency hospital model. In focusing on the rural emergency hospital model today, we'll be discussing an overview of the model, certain requirements that exist for rural emergency hospitals, and finally what resources and opportunities exist for the model in our state. With that being said, the REH designation was created to preserve essential services rendered by small rural hospitals in the United States that often act as cornerstones for providing health services to rural communities. This is the first new Medicare provider type created by CMS since the COB model was ratified in 1997, And through this designation, hospitals with 50 beds or less as of December 27, 2020 are able to render a specific set of services with a supporting payment system in place. The services rendered by REHs are limited to emergency department services, observation care, and outpatient and medical health services. In addition to this list, hospitals must also close inpatient services, relinquish eligibility for the 340B program, and reduce annual length of stay to less than 24 hours, all of which are illustrated by the graphic shown here on this slide. These are just a few hallmarks of this model to consider now as we go through some of the factors that precipitated why there is a need for the REH model in rural healthcare and here in South Carolina. In looking at the current state of hospital closures here in South Carolina and across the United States, one can begin to see why rural hospital models serve an important role in providing alternatives to complete closures. Within the United States, 190 hospital closings have occurred since 2005. With regard to South Carolina, I want to point out to this map here on the right, which really works to illustrate the number of closures that have occurred in this time period in our state. With 4 rural hospital closures occurring in our state, it facilitates the discussion on what rural hospital challenges exist that are causing these closures. In references to challenges, I want to point out a few that have been identified through current literature and our state's healthcare landscape, while also noting that this is not an exhaustive list of issues that rural hospitals are facing in our state. With that being said, since before the creation of the critical access model to the rollout of the REH model in today's time, rural hospitals have and continue to experience issues related to regulatory challenges, access to care, declining reimbursement, low patient volume, and workforce shortages, many of which have been exacerbated by the pandemic and that will continue to be a problem after the public health emergency ends within the next couple of months. In drawing attention to those challenges in rural hospital closures, I hope to highlight some of the underlying reasons that the REH model has been created and why it serves as an important new Medicare type in addition to the critical access hospital model. As the hospital closures discussed began to persist after the creation of the critical access hospital model, health systems began to witness the emergence of freestanding emergency departments. However, with these facilities, there was no specific federal designation for operation in rural areas, which prompted the need for new legislation. Such legislation was initially introduced through acts such as the REACH Act of 2015, but was not ratified until the Consolidated Appropriations Act of 2021. At that time, the Rural Emergency Hospital was made available to critical access hospitals and small rural hospitals with less than 50 beds as of the date of enactment of December 27, 2020. The REH model works to reduce additional hospital closures by allowing rural hospitals to provide solely outpatient services under a certain set of criteria and requirements, those of which we will discuss now in more detail. The REH model was really created with 3 main stakeholders in mind. These are outlined as critical access hospitals that have already received the critical access hospital designation and that operate with 25 beds or less. There are currently 3 critical access hospitals in South Carolina. In addition, hospitals that operate with 50 beds or less that are located in a rural county or have received an active reclassification from urban to rural. And finally, rural hospitals that were eligible for the REH model on the date of enactment of December 27, 2020, but have subsequently closed since that time. With these 3 facility types in mind, the REH model allows for rural hospitals to operate under this designation through a specific set of requirements. In going through each of these requirements, I hope to provide a better understanding of the REH model in showing that to operate as a rural emergency hospital, hospitals cannot provide acute inpatient care services. They have to have 24-hour emergency services available with an annual length of stay less than 24 hours. In addition, these hospitals have to be certified Medicare participants, and they have to have a transfer agreement that exists with a level 1 or level 2 trauma center. In addition, REHs have to meet state licensure requirements, more of which we will discuss in the policy implication of today's webinar. Finally, these hospitals have to meet emergency department staffing requirements and meet staff training and certification requirements. In addition, REHs have to meet any conditions of participation, some of which we'll take a look at today, that are applicable to cause for emergency services and really are just similarly modeled after the critical access hospital designation. First, I want to draw attention back to the REH specifications in discussing the specific payment system of this designation type. Under the Rural Emergency Hospital, outpatient services are rendered at the traditional outpatient prospective payment system rate plus an additional 5%. Co-payments are also given based on the current OPPS system, with skilled nursing facility services, should they become applicable, rendered under the prospective payment system. In addition to these services, ambulance services are rendered under the current ambulance fee schedule released by CMS, and should there be a rural health clinic operated by this hospital, it would be reimbursed at the same rate as a hospital with less than 50 beds. Any services I've not discussed through this list are rendered outside of the OPPS, are paid under their respective fee schedule. Now, in addition to this OPPS rate, I also want to note the additional facility payment, because in addition to the payment methodology we just discussed, REHs receive an additional monthly facility payment that I would like to take a minute to break down. This facility payment for calendar year 2023 specifically is based on the COB Medicare spending and prospective Medicare spending from calendar year 2019, which you can see in the first row. This is then broken down by the existing number of COBs, which means that REHs can expect to receive around $272,000 per month and an additional payment, or around $3.2 million per year, and this is highlighted in the second row. Overall, this payment system and additional facility payment given on a monthly basis is seek to aid hospitals that will now eliminate provision of inpatient services, but it's also important for hospitals to realize, and those that are considering conversion, to analyze how these changes in payment methodology would affect their system, as well as how the conditions of participation outlined under the REH model would affect them, to see if this model would be feasible for their specific hospital. Now, at this time, I want to discuss a few of the key considerations made apparent through the conditions of participation outlined under the REH model. With regard to provision of services, hospitals are expected to meet policies that include a description of services and how they must be rendered by each REH. For emergency services, REHs have to be in compliance with current COB requirements and anything that is outlined in the Code of Federal Register for the conditions of participation. In addition, hospitals need to consider that they have to have an active facility-wide program for infection prevention and control that is going to look for surveillance, control, and prevention of infections, coupled with their ability to demonstrate that they are utilizing antibiotics through a stewardship program in their hospital. The last thing I will point out on this slide is that an RH also has to be staffed 24 hours a day, 7 days a week, and they have to meet the cost staffing requirements outlined through those conditions of participation. The last 3 conditions of participation that I want to take a minute to note are patient rights, and that REHs have to promote and protect patients' rights in compliance with state and federal requirements, and that REHs need to consider that they have to have an existing agreement in place with a level 1 or level 2 trauma center, which will be important in the application process, because hospitals looking to convert must demonstrate that they have these agreements in place. Finally, REHs had to demonstrate that the physical condition of their hospital ensures the safety of their patients, and they have to meet any other conditions of participation that include but are not limited to those that we have just discussed through these slides. Now, for hospitals who have now seen these eligibility criteria and requirements and are considering converting to the REH model, there is a designated process in place for the application process through our hospital and through rural stakeholders such as the Rural Health Redesign Center, or RHRC. Through this process, we wanted to break it down through this process map, in that hospitals that apply will need to submit an application through our office. Now, as part of this application, it does expect hospitals are already certified Medicare participants, so it is a scaled down version of the CAW application. However, hospitals will need to fill out a CMS 855A form, which denotes a change in designation. They will need to develop an action plan that demonstrates how they plan to eliminate services in their hospital. Again, with the transfer agreement, this is something that they will have to show is actively in place. And they have the option to submit a letter of attestation, which just shows that they agree to meet the conditions of participation that have been outlined through this model. Once that is submitted and reviewed through our office, it is then transferred to the CMS regional office, which at that time, they would then authorize a survey. This survey is not mandatory in that at the start of this application process, it may be conducted at a later time if that letter as the last part of the application process is submitted. But should the CMS regional office proceed to go through with the survey at that time, they would contact the state survey agency, which in South Carolina is SCDHEC, and all of these applications would be, all of these materials would then be submitted back to CMS to be reviewed by the state agencies and by the CMS regional office. Now, during this time, the 855A will also be transmitted to the Medicare administrative contractor for our state, who will approve or deny this paperwork. Within South Carolina, Palmetto GBA serves in this role. And again, all of these stakeholders will facilitate the final application review and review that hospital whether or not they have been notified and whether or not they've been approved for the REH status or not. Now, throughout this process, SCORE and RHRC are able to facilitate technical assistance through 3 different areas. This process of technical assistance starts by identifying hospitals that are interested in applying for the REH designation. Second, it works by providing REH education and training, such as through webinars like the one provided here today, and engaging rural hospitals, again to see if this is something they would consider. And then finally, as an office and in working with RHRC, we're able to facilitate the application for this designation type through the process that we just discussed. It is also important to note that the Rural Health Redesign Center, or RHRC, serves as the national source for providing technical assistance to REHs. For any hospitals interested in converting to the REH designation, they would need to seek assistance from this stakeholder that provides resources through a cohort model. Now, we have listed how that cohort model functions here on this slide, but really in looking at the timeline provided here, you can see that this is about a year-long process that is broken down into 3 phases. For the current cohort that has started with engagement and education that started around October and was facilitated through March of this year, that then was followed with financial assessment in the second phase of this process to determine if these hospitals that are interested in applying, if this is a feasible option based on the payment methodologies that we have outlined. And finally, this is capped off with the application and conversion strategy development with RHRC to help these hospitals walk through the application process. Hospitals should consider that the current cohort and first cohort is already underway and how upcoming cohort timelines would correspond with the hospital's objectives before applying to REH status. As you can see from this slide, engagement for the second cohort has already been expected to begun, and that process will tentatively go through June. So if this is something your office is considering, your hospital is considering, you should reach out to RHRC. With these technical assistance resources in mind, our office has highlighted a few opportunities that may exist for hospitals to convert to the REH designation here in South Carolina. Currently, there are 26 rural hospitals here in the state, highlighted by all of the points on this map. And by looking at retrospectively at cost reports from December of 2020, our office was able to prospectively identify a few rural hospitals that might be eligible for the REH status. These 10 rural hospitals identified and 3 CAUSE that might be eligible are illustrated on the right in orange. So altogether, 13 possible opportunities to convert to REH status may exist. However, hospitals would need to determine if they are in compliance with the conditions of participation, the requirements, and whether or not delicensing to the number of beds required by this designation type would be feasible for their hospital. But overall, really, this map and these opportunities exist to highlight that there may be opportunities here in South Carolina through the REH designation. Now, a full list of these 13 hospitals that have been prospectively identified are listed here. And again, based on the number of beds of these hospitals as identified by cost reports from December of 2020, which is listed in the right column. As you can see, 10 of these hospitals act as rural PPS hospitals, while the other 3 are the current critical access hospitals in our state. And I will briefly pause on this slide to give a chance for hospitals to scan through this prospective list. So now that we have reviewed that list and have those hospitals in mind, it is also critical to note that in keeping with the REH requirements, REHs must meet all state licensure requirements. And at the current time, the state of South Carolina is not one of the 7 states listed here that have existing requirements for the REH model. Currently, those states are Arkansas, Illinois, Kansas, Michigan, Nebraska, South Dakota, and Texas. In simplest terms, this means that should a hospital seek to convert to the REH status, They would need to engage our office so that a plan can be enacted to engage policymakers with regard to creating RAH licensure in our state. However, interest in converting would serve as a first critical step to achieving this goal, which is really why we wanted to outline technical assistance that is facilitated through our office so that you know that should you be interested, you can contact us or RHRC in facilitating this process. With that being said, I do want to end today's webinar by thank you for joining us here at SCORE to learn more about this important model and the opportunities that may exist in our state. But I will leave my contact information here and for our office so that if you have any additional questions, feel free to reach out to us here at SCORE. But thank you again for tuning in today to learn about the Rural Emergency Hospital designation.